Of who I am. So I have a Bachelor of Science in Pharmacy at the University of Toronto and a pharmacy residency at the Ottawa Hospital, and I completed my Doctor of Pharmacy at the University of Toronto. I currently practice as a clinical pharmacist at the Toronto Academic Pain Medicine Institute, better known as TAPME, at Women's College Hospital. Some things with regards to teaching, I precept some of our pharmacy residents at Women's College, as well as some PharmD students at the Leslie Dent Faculty of Pharmacy. I am an active member of the national faculty at McMaster Pain Center, so the McMaster University Michael DeGroot National Pain Center, as well as I facilitate within the U of T interdisciplinary or interfaculty pain curriculum, what we call the Pain Week. I've presented in different conferences, both provincially and nationally, around pain management, opioids, and cannabis safe practices. So certainly you can see I have a big passion around chronic pain and a management of. So I hope to distill some of these aspects to you in the following presentation. Here as well details some of my disclosures. I have no current or past relationships with commercial entities, as well as my commercial support disclosures. Okay, so today's learning objectives, by the end of the session, you'll be able to discuss the opioid-related risk and public health crisis in Ontario, list the clinical rationale behind opioid dose limitations, describe some strategies to promote safe and effective opioid use, and then with regards to opioid therapy adjustments, identify who would benefit from an opioid taper or rotation, describe how one would facilitate that conversation with patients as well as physician colleagues, and then finally explain the steps involved in initiating a rotation or taper. And we'll go through a couple of cases to describe some of these strategies. So you can see here, it's no surprise in the media, in the newspaper, on TV, that we are amongst a public health crisis or the opioid crisis. And a lot of these headlines shows us a lot of the overdose risks associated with fentanyl overdose, overdose associated with misuse of opioids, and that there's a huge financial toll on the healthcare system, both from a patient point of view as well as a societal point of view. So a lot of this has driven a lot of the policy changes that you have been seeing in the last month or so, and we'll highlight some of these policy changes and its effect on our safe management for our patients. If we narrow in to the trends in Ontario, you can see here from 2003 to 2014 that overall about 41% of patients using long-acting opioids exceeded that watchful dose of 200 milligrams. And in fact, now the watchful dose has changed to 90 milligrams, given the recent publication, 2017 publications. And we'll highlight that in a few slides. 56% of those are long-acting oxycodone, and about 70% or 76% are transdermal fentanyl users. If you look closely at the slide, you can see that despite the changes in the guidelines in 2010, it has led in a decline in opioid prescribing rates among ODB beneficiaries, but it hasn't really resulted in significant changes in opioid-related hospitalization and mortality. So high doses are still being prescribed despite changes in guidelines, and this suggests that we need improved strategies and programs for the safe prescribing of these long-acting opioids. You can see here we have an updated slide as it relates to opioid prescribing trends in Canada. And we have data from 2013 to 2018 of about 4 provinces within Canada, giving us a proportion of patients prescribed opioids. And these are data captured from prescription opioids used primarily for pain or cough suppression, but not for OUD or opioid use disorder. So you can see on the right-hand side some key statistics drawn from this study and from public health, that 1 in 8 people are prescribed opioids within these 4 provinces, which translates to an estimated more than 4.6 million Canadians nationally. 1 in 5 people are prescribed opioids in the long-term basis. So long-term opioid use is defined as someone prescribed opioids for approximately 90 days out of a 100-day period. So about 3 months period of opioids. And then there's also data to say that 1 in every 550 people on long-term opioid therapy die roughly 2.5 years after the first opioid prescription. So that's pretty significant when you think about patients, how long they've been on opioids. That certainly there's a mortality risk with regards to duration of opioids. And furthermore, there's also linked with the mortality as it relates to dose. So 1 in 32 patients that are using opioids over 200 morphine equivalency die of opioid-related causes. So these are significant figures, and over time we can see that the proportion of patients haven't changed. So there's still lots of work that has to be done to really change that curve and change this long-term prospect of opioid use. So here you have from Public Health Ontario some more updated data of the cases of opioid-related mortality and morbidity within Ontario itself. You can see the data extends from 2003 all the way to 2018, end of 2018. And there's 3 key factors they were looking at. So I'm going to draw attention first to the purple line, which is ED visits. So over time, you can see a huge spike from 2016 to 2018, a huge jump of almost up to, over 9,000 patients in 2018 were presenting to the emergency due to opioid-related issues. Of those, you can see that about 1,500 patients actually had to be admitted for opioid-related issues, and then the death aspect. So, we can see here the line continues to climb, and these are significant numbers that almost 2,000 patients had to suffer mortality outcomes due to opioid-related issues. So these are significant, and despite all the changes of policy and changes in practice or attempts with regards to guidelines, we still continue to battle with quote-unquote this opioid crisis because the death rates continue to rise and the sequelae to opioids continue to rise. So part of that data set, they also looked at the age group. So you can see here in 2018 that the age group that is most significantly affected by opioids is age 25 to 44, which is concerning with regards to a public health perspective. This is a group of patients that are in school or contributing or should be contributing to society. These are young adults that are really supposed to be active within the community that are really affected by the opioids. What's concerning too is the second biggest age group is 45 to 64. So again, the working population is affected by the use of opioids. And this hasn't really changed from year to year. It seems to be these 2 groups that are affected by the opioid use and the sequelae related to opioids. So the first question I want to pose to the group is about opioid mortality and dose. Patients on stable high-dose opioids are safe to continue on such doses. And you can see here that that's a myth. And really it's based on clinical opinion. Certainly there's no strong evidence suggesting that there's an absolute appropriate dose threshold or epidemiological data that I'll be presenting, that the higher the dose, the higher the risk of overdose death and mortality. So let's talk about a very landmark trial done by Gomes and colleagues in 2011. Landmark being the number of patients that were included, as well as the generalizability. It's a population-based case control study done from 1997 to 2006, looking at Ontario citizens, so through the Ontario Drug Benefit, between the age of 15 to 64, and they excluded prescriptions for palliative or cancer patients. The cases were identified as opioid-related deaths through coroner's data, so they were able to confirm that through toxicology, that indeed this patient died of an opioid-related death. And then the controls were also prescribed opioids but did not suffer mortality, and they were all matched with age, sex, past drug use, as well as comorbidities and diseases. They looked at dose determination of opioid prescriptions and average daily dose overlapping at that time of death, and they compared it to the lowest dose stratum, which is at less than 20 milligrams morphine equivalency. That was a reference group. And what they found was very, very interesting. So you can see in the graph here, in the red box, that anyone taking doses above 200 morphine equivalency, when they compared the cases and controls, that an adjusted odds ratio showed a more than 2 times increase in mortality and morbidity for such patients. If you look down at the other stratum at 100 to 199 morphine equivalency, there's still that increased risk signal of at least 2 times greater odds ratio of opioid-related mortality. And then even further down at the 50 to 99, there's still increased risk. So I think this study really helps us the safety of the watchful opioid dose and its significant association with high dose and mortality, and that very high doses are accompanied by large increases of harm. This study also suggests that daily doses exceeding even 50 to 199, which is very common in practice, is also associated with an increased risk of death. So perhaps this data, as well as a lot of other data that has come out, has really led to changes in what we consider now the watchful dose. Another thing that we want to keep in mind is about chronic pain and addiction. So patients receiving prescription opioids for chronic pain do not develop addiction. Is that a fact or a myth? And in fact, we know that's more of a myth. We know that recent research has since suggested that 5 to 10% of patients prescribed opioids for chronic pain actually develop some sort of addiction or a degree of addiction, whereas the rates of misuse, abuse, and addiction-related aberrant behavior, any behavior that is suggestive of misuse, crushing, chewing, double doctoring, have ranged from 15 to 26%, so much higher than we once thought. When we look at this study here, done by Sproul and colleagues, so Beth Sproul is a pharmacist at the Center for Addiction and Mental Health. In 2009, she did a retrospective analysis of patient health records from the Medical Withdrawal Management Service of KMH. And most of these patients had significant comorbid pain. Certainly psychiatric conditions and other psychoactive substances were issues. But when she looked at the source of the opioids, you can see highlighted here that almost 50% of patients receive their opioids from a prescription, so a legitimate prescription for chronic pain. So this is a misconception that's led to the overconfidence and overprescribing among clinicians due to the belief, or the belief back in the day, that pain protected us from developing opioid addiction. But research has now shown that patients on opioids for pain can become addicted, and that even when the drug is taken as prescribed. And the thought is that for patients in chronic pain, even a mild level of pain can trigger that learned association between pain and drug relief. Such a conditioned urge for relief, even mild pain, can lead to that early or inappropriate use of opioids outside of prescribed scheduling. Furthermore, another study done by Edlund and colleagues in 2014, more recently, looked at patients newly diagnosed with chronic non-cancer pain. And this was U.S. data showing from 2000 to 2005 of over 500,000 data points. And it excluded those with prior opioid use disorders or use issues, as well as cancer pain and nursing home residents. What they wanted to look at is the association between opioid days supplied, so no supply, acute use, and chronic use, and detailed there, as well as average daily doses, so no opioids, low dose, medium, and high dose. And then they wanted to see that association between those factors as well as new diagnosis of opioid use disorder. And what they found here was that even at low doses, acute use has an increased odds ratio of developing addiction. But what is most significant is that as a patient proceeds from acute to chronic opioid use, the evidence of efficacy we know decreases, whereas the risk of developing opioid use disorders or risk increase substantially. So you can see in the red that I highlighted that it's really the chronicity that drives a lot of this development of opioid misuse or addiction. And then even low doses poses much less risk, but once you chronicify that, that's where the risk factors developed. Certainly there are risk factors of younger age, and a history of substance use disorder or the history of mental health disorders are all associated with opioid use disorders. But this just gives you a sense that really, despite having chronic pain, misuse and addiction is a real concern. So given that we understand the risk, we know that now the inappropriate use and abuse and diversion of prescription opioids has emerged as a significant public health safety issue in Canada. And in response to that, the government has done a couple of policy changes, and one of the biggest ones were done almost over a year ago, was the delisting of the high-dose opioids. So as of January 2017, the following opioids were delisted from the Ontario Drug Benefit, and it's listed for you there. Now, the ministry made a commitment to review the funding status of opioid medications and made changes necessary to hopefully improve and encourage appropriate prescribing. and they had drafted a pain subcommittee that convened to review the class of opioids for pain management. And there were many experts involved in this discussion, including experts in pain, addiction, palliative care, clinical pharmacology, internal medicine, etc., family practice, as well as pharmacy. And based on a lot of extensive discussion, the pain subcommittee, as well as further considerations and recommendations by Ontario Committee to Evaluate Drugs, decided to delist these high-dose opioids. Now you can see in the box there that the delisted opioids would not be considered under exceptional access, so the EAP program, or the compassionate review policy. Lower strength, long-acting opioids will continue to be funded through the ODB program. There are a couple of exceptions to this legislation, so access to high-strength, long-acting opioids is maintained for patients requiring palliative care, and they can obtain such opioids through these programs. But you can see highlighted there in both circumstances, patients must have a progressive life-limiting illness requiring these high-strength, long-acting opioids for palliative reasons. So why do we limit the opioid dose? I think there's a lot of clinical rationale behind why we do so. So certainly the first one that comes to mind is central sensitization or opioid-induced hyperalgesia, and I'll describe what that is in the next few slides. There's opioid withdrawal-mediated pain, medical complications, as well as increased risk of addiction and overdose and death, which we've discussed extensively. So the first clinical phenomenon is opioid-induced hyperalgesia, and the definition is laid out here. So it's a nociceptive sensitization caused by exposure to opioids, characterized by a paradoxical response whereby a patient receiving opioids for the treatment of pain can actually become more sensitive to certain painful stimuli. So really there's an amplification within the CNS, resulting in more intense perception of pain, thereby maintaining that chronic pain experience. And other aggravating symptoms of central sensitization, so poor concentration, fatigue, and constipation is also seen. The thought is it's that NMDA is activated or overactivated, and it causes a calcium influx into our cells. And by virtue of that, the neurons are hyperexcitable, and they enhance that transmission of pain impulse via substance P and glutamate, to name a few. So therefore, you have a lot more pain signals bombarding the CNS. And the features are more diffuse or less defined pain, and oftentimes the pain extends to other areas of distribution. Potential treatments, we think maybe ketamine, maybe methadone, and maybe buprenorphine through a kappa antagonism. But certainly this condition is very hard to manage, and the only way we can really try to reverse it is to lower the doses or taper a patient off of the opioids. Now, I've seen this oftentimes in clinic. You know, a patient will present with very localized low back pain, and they would shade in their back, lots of pain around the lower back, and then start on opioids. And over time, in about several years with the dose escalation of opioids, now they come back to clinic and now they have shaded the entire body. And this, of course, is barring any additional pathology or fractures. So you can see that the pain experience and the pain pathophysiology has changed in this patient and has become more hypersensitive and diffuse. Another interesting phenomenon is called withdrawal-mediated pain. In some patients, they notice that as the time for the next dose is approaching, they feel pain all over the body. So this diffuse myalgia, they may say that they're unhappy or unwell or dysphoric, and this phenomenon is classified as withdrawal-mediated pain. So very similar to withdrawal symptoms. So as you can see here, the dose-response curve, as you dip low in the dose, getting ready for the next opioid dose, you have these symptoms start to emerge. So as the amount of opioids start decreasing in the body, the patient experiences more withdrawal symptoms. And this withdrawal-mediated pain usually occurs when patients take high doses of opioids. And I think what happens is oftentimes we don't recognize this and we start to escalate the doses. They're building tolerance, it's no longer working, and then therefore you continue this vicious cycle of withdrawal-mediated pain.
So I want to highlight, some medical complications we want to consider when we think about opioids. And these are, considerations that often a lot of patients aren't aware of when they begin opioids, but certainly something that we want to draw their attention to. So the first one, and this is again not by order of incidence, but just a listing of what we often see in practice. So reduction in sex hormones. So in women, you would see a presentation of irregular or loss of menstrual cycle. In men, we would see concerns around erectile dysfunction, impotence, or decreased muscle mass. And in both genders, a loss of libido and potential effects on fertility. So what I'm really talking about is a reduction in testosterone. So that certainly is a link with opioids, high dose, long-term opioids. We see patients have reduced testosterone levels. Central sleep apnea and or disordered sleep is a very concerning medical complication because we know opioids bind to that sleep center within our central nervous system, affecting the way and the drive to which we breathe when we sleep. So when someone has central sleep apnea, you add on opioids, you further worsen that, or you cause a development of that, and that increases that risk of overdose when they fall asleep. Medication overuse and opioid-induced hyperalgesia are pretty, in some ways related. Hyperalgesia we discussed in previous slides, you have that increased sensitivity of pain. So similar to medication overuse, you have the development of these chronic headaches, or what we almost similar to rebound headaches. Once patients get on opioids, these headaches get worse and worse and more chronic, and they're harder to abort. And again, it has to do with the changing of the pain pathway and the changing of the sensitivity of pain due to opioids. Immune function or impaired immune function, so effects on T cell function, increasing that risk of infection long term, and then lower bone density and risk of fractures. So this again likely is linked back to testosterone and sex hormone balance, affecting that bone health and bone strength. And last but not least is opioid use disorder. So I put this as a medical complication because yes, I believe that the use of opioids certainly can lead to the development of opioid use disorder. And as a result of that, that's considered more of a complication, right? This is a sequelae of these opioids that can lead to addiction issues.
So I want to now launch into talk about the most recent National Opioid Use Guidelines coming out of McMaster in 2017. They came up with very concise guidelines of 10 recommendations, highlighting when to either initiate opioids in the general population, when to initiate those with risk factors such as psychiatric illness or substance use disorders, how to carry out an opioid trial, so this about opioid dose limitations, tapering and or rotating, and they also included some qualifying remarks and values. So this helps to facilitate that accurate interpretation of the guidelines. They divided the recommendations into strong recommendations. So this means that for that particular recommendations, almost all informed patients would choose this recommended course of action and as well supported by strong evidence. Weak recommendations indicate that there's a majority of patients would choose this course of action, but many would not. And then in this situation, clinicians would recognize the different choices that would be appropriate for an individual, and they should collaborate with that patient to come to a good decision consistent with that patient's values and preferences. Okay, so the first recommendation I want to highlight here is stated here. So for patients with chronic non-cancer pain who are beginning opioid therapy, so this is through initiation, we suggest restricting the prescribed dose to less than 90 morphine equivalency daily, rather than having no upper limit or a higher limit on dosing. And this is strong recommendations. Now, the qualifying statement is that some patients actually may gain benefit at doses more than 90, but I think in this case you want to refer to a colleague specialized in this area for the possibility of increasing the dose to more than 90, and therefore that might be warranted in those patients. Again, going back to that discussion with Tara Gomes' study, we know that the risk of mortality and morbidity really climbs even above that 50 mark and even further or more above 90. So I suspect that a lot of this is driven by this recent data that we're seeing. Now, for patients who are currently with chronic non-cancer pain, who currently are using opioids and have persistent problematic pain or problematic side effects, they suggest rotating to another opioid rather than keeping the opioid the same. This is a weak recommendation because there's really been low evidence suggesting that substitution or a switch in opioids would strongly reduce pain or adverse effects. But I think, despite that, I think rotating in patients in parallel as a way of facilitating dose reduction is something we do very commonly in clinic and from a clinical perspective. And anecdotally, we know that there's a lot of patients that actually get better pain relief with that new opioid at that lower opioid dose, as well as they have mitigate some of the side effects that they may have experienced from previous opioids. So certainly this is a modality we use in practice to help shift that risk-benefit balance. Okay, and then moving on into obviously continue with patients currently on opioids. So if they're using 90 morphine equivalency of opioids per day or more, they suggest actually tapering the lowest effective dose, potentially including discontinuation rather than no change. And again, this is a weak recommendation. And the qualifying statement is that some patients may have substantial increase in pain or a decrease in function that persists more than 1 month after even a small dose reduction. So in that situation, we want to be flexible, and tapering may be paused or potentially abandoned in such patients. Again, this is based on low evidence or low quality evidence, but anecdotally we know that most patients, when they taper, actually don't get worsening pain. Their pain may stay the same, but at least this is at lower doses. And in some patients, they have reported to me better pain relief, so maybe that's mitigated through that improvement in the hyperalgesia, as well as better side effect profile. So despite the weak evidence, we still promote tapering modalities. And then the last recommendation I want to highlight that's relevant to our talk today is for patients with chronic non-cancer using opioids and experiencing serious challenges in tapering, we recommend a formal multidisciplinary program. So this is a strong recommendation backed up by strong evidence. And I think, you know, the caveat to this recommendation is that we know the cost of a formal multidisciplinary opioid reduction program is enormous, and there's limited availability and resources, especially in smaller towns and underserviced areas. Certainly in Toronto, we're very lucky. We have a lot of programs, but we have a lot of patients that come from out of town in Northern Ontario that don't have access to these multidisciplinary teams. So I think one of the qualifying statements from the guideline group was that we can think of different models of practice, that the primary care physician, in collaboration with maybe different or several healthcare professionals who they can access, can work on a taper or can work on a plan of tapering. And they highlight the pharmacist as being one of those clinicians. So I think that's very promising from our perspective as a profession, that this is our opportunity to help physicians, to help patients to address this opioid crisis, and that really we're at the forefront in driving a lot of this safe use of opioids. And I encourage you guys to take on that challenge. So now we're in a situation where we want to think about tapering a patient. So who may need an opioid adjustment? So in the gray here, I just want to kind of park that there are certainly patients that opioids are indicated. So patients with well-defined pain conditions, either nociceptic and neuropathic, and who are getting good functional outcomes and benefits from opioids. Okay, so maybe they're indicated. Patients with active cancer, as well as end-of-life or palliative care, those patients, there is indication for ongoing opioid use. But I think there's a bigger population of patients where opioids are probably not the safest or not appropriate, and they're listed here for you. I just want to highlight a few because you have them on your slides, but relative contraindications are those patients perhaps with social instability or irresponsible opioid use, certainly those with past substance abuse or unstable mental health issues, and then the pregnant population. So this is a bit of a higher risk population that you may want to look at other alternatives. Back pain, headache, and fibromyalgia is a soft contraindication in that there's really not a lot of evidence and data supporting the benefits of opioids in these conditions. An absolute contraindication, I know in science it's hard to say absolute, but I think this is probably pretty strong contraindications. Patients with current substance abuse, those with absence of pathology, and then certainly those are engaging in active legal activity related to opioids. Those patients, we want to avoid the use. So this slide basically reiterates what I'm saying. So when do we adjust opioid therapy? 3 big criteria to think about. So certainly benefits, so no improvement in pain or function. So we consider a clinically significant improvement in pain as a 30% reduction in the visual analog scale. So let's say a patient says their pain is 7 out of 10. Taking the opioids, they bring it down 3 points to 4. So that's considered clinically significant, or as good as it's going to get. But we want to pair that with improvement in function too. I think that's a much more meaningful outcome to measure, making sure the patient's able to get back to doing things that's important to them. Patients who request a taper, as well as a resolution of their pain condition. In the middle box, we have abuse risk, so certainly patients with concerning aberrant drug-related behaviors or an active opioid overdose event. And then the last box is those adverse effects we talked a lot about, so either side effects or very concerning medical complications. All those conditions are what we consider probably fair conditions to think about, to consider or have that discussion with patients about tapering. So how do we intervene? I think I want to highlight here that doing an opioid taper, the science behind it is not hard, right? There's certainly many guidelines on how fast you taper, what are the numbers, how much you reduce. But I think really the art behind tapering is the communication or the soft skills that we need to work on as pharmacists to move that patient along that stage of change, to engage in the taper. So certainly you can use techniques of motivational interviewing, which is a collaborative, patient-centered form of guiding and eliciting and strengthening that patient's own motivation to change, to address any of their ambivalence. And that's a separate talk into itself. It certainly is a very specialized skill that a lot of pharmacists are learning to help in moving along the stage of change. And this relates to many type of medication use behaviors. Understanding the patient's stage of change, understanding the specific, measurable, achievable, relevant, timely goals. So setting those SMART goals to focus on improving quality of life through better function. Education and support of patients and prescribers. So I can't stress enough why this is important. I think a lot of times patients are hesitant to taper because of lack of knowledge, the knowledge gap of understanding the risks associated with opioids and what does a taper look like. So you may say things like why you're concerned about the dose of opioids. Explain the process of tapering, right, and describe what they can expect. Would they expect withdrawal symptoms? When would that occur? How do they manage? And then providing that patient resources to pain education groups, right, to support other pain coping strategies, other non-pharm modalities such as CBT or acceptance commitment-based therapy like ACT, to name a few, physiotherapy, etc. So again, really a holistic look on managing pain. So also to continue on how do we intervene, we want to make sure we develop that therapeutic relationship. And I don't need to tell you guys or explain that. I think it's pretty obvious that in order to elicit change in a patient, we have to have that good therapeutic relationship. So that is developed through trust, respect, support, and being non-judgmental. And I can't stress that enough in this area of chronic pain. I think a lot of patients feel very stigmatized by being on opioids. So by being non-judgmental, explaining your role, and having empathy towards their suffering and pain is a first step in opening up that discussion. And I think for pharmacists, there's no power imbalance or negotiation. We don't hold the prescription pad, and we can't threaten that we're not going to prescribe if they don't behave a certain way. I think that allows us to have that open discussion with that patient, that open and very transparent discussion about risk and benefit and your concerns. Assessing readiness for change. Managing expectations is huge. I think a lot of patients expect that opioids are a panacea. So they would cure my pain, take away all my pain. And I think by giving that education that no, actually opioids, if we can expect any clinically significant benefits, 30% reduction. And we know that there's not long-term clinical benefits in terms of function. So giving that patient that education and then yet helping them weigh the risk and benefits that you know in the data and what we hear now is very important so that the patient has a well-informed, balanced view of opioids and can make that informed decision. And then making that change takes several encounters. So Rome wasn't built in one day, and patients often aren't on opioids just for a year. They're on for 5+ years. So it's going to take many, many encounters and discussions to move that along that stage of change to get them ready to taper. Okay, so I alluded to this whole stage of change. So this is described to you here in this schematic. So patients can cycle between many stages. Stages of change is very cyclical and dynamic, right? So patients can typically move back and forth between a stage, cycle through that change many times. They can move very quickly and pause at one area or linger. So patients can start off being pre-contemplative, so they have no intention to change, so they may. Okay, so I alluded to this whole stage of change. So this is described to you here in this schematic. So patients can cycle between many stages. Stages of change is very cyclical and dynamic, right? So patients can typically move back and forth between a stage and cycle through that change many times. They can move very quickly and pause at one area or linger. So patients can start off being pre-contemplative, so they have no intention to change. So they may say, I won't change, or I can't taper, I'm not going to do it, I'm not ready. So in this stage, I think as clinicians, what we can do is provide information on benefits and risks. So just lay out, this is why I'm concerned. You're not coercing, you're not forcing, you're not pushing, you're available. I'm here for you to talk when you're ready to think about this, and utilizing those skills of motivational interviewing to move that patient along the stage of change. Once it becomes contemplative, the patient becomes ambivalent. So they may say things to you like, I see why it's safer to taper, however, the pain is just so bad. So again, here your role is to address that questions, those knowledge gaps, continue to raise awareness of the pros and cons of opioids, and then use MI. And then finally, if we're lucky enough, patients move towards that preparation stage. So patient has intention to take action. What if I taper? I think I'll feel so much better. So here we help to develop that plan of action, that taper plan. What does it look like? And I think I would argue that you probably can talk about withdrawal management too, right? So that the patient has a full concept of what it's going to look like. Then finally, the patient's in action. So they implement that behavioral change. I'm going to do it. I'm tapering. So continual monitoring, continual support, because certainly throughout the taper, there's going to be roadblocks and challenges where you may pause or have to go back a little bit. Again, continue to validate the patient and promote self-efficacy. And then maintenance. So patients have sustained that behavioral change. And, here you provide that continued support to ensure that they continue to move along that safe opioid use trajectory. Okay, so I think one of the biggest challenges is, patients that disagree or are pre-contemplative. Majority of patients that come to me through consult are usually pre-contemplative, and this is where we have to do most of the work to help move them. So they can disagree with tapering for a variety of reasons. Certainly there's personal experience, influence the feelings around tapering. They may have had a really negative experience in the past. They might have been tapered very rapidly, experienced these really uncomfortable side effects or withdrawal symptoms. They may have psychological barriers, so beliefs that they're about themselves, about their ability and self-worth to pull through a taper, fears and beliefs, and then again, like that knowledge gap, misunderstanding what it looks like to taper and what would happen to them. So I think in this stage, we want to communicate by asking, listening, informing and educating, and encouraging the patient. And we want to practice that spirit and principle of motivational interviewing. So MI is, very quickly is made up of main components for the basic interaction. So the acronym we use here is OARS. So O stands for open-ended questions. So you invite that patient to tell their story. So you may say, what are some of the concerns you have about tapering your opioids, or what is holding you back? And then you listen to the patient's story, and then you try to get an understanding of what their ambivalence is. A stands for affirmation. So these are statements that are genuine and recognizes the patient's strengths and validates their feelings and experience. So it's not about saying you're awesome or praising them, but it's just telling it how you see their patient experience. So you might say, you've given this taper a lot of thought and have made that difficult decision to begin. So affirming. R stands for reflection, so proving that you're listening and understanding. So you may want to form a hypothesis of what you think they mean to say. So what you're saying is that you're afraid that if we make changes to your dose too quickly, you'll suffer from withdrawal. So this allows a patient to correct your understanding, or they may say, yeah, you're right. And then finally summarizing, so checking the understanding of the situation. And that can be used to link that ambivalence to change talk, right? So again, that was a very quick summary of MI, but I think the key is to be collaborative, understanding their motivation and values, and respecting the patient's autonomy. And really, I think this is a very impactful way to move that patient. Okay, and a little more about MI. So the principles of MI. So again, we talked about the spirit. The principles can be based on this acronym, RULE. So RULE, R stands for resisting that righting reflex. I think as healthcare providers, we have the desire to fix things. And this is a problem because, especially with patients who have a tendency to resist any persuasion they're, a bit ambivalent, pushing them or trying to, correct that behavior is certainly going to backfire. It's not going to move that patient towards that stage of change. So you want to roll the resistance. So until that patient's ready. So you may say things like, I can see that you're not ready. I can see that there's a bit of hesitation in making changes, and that's okay. And when you're ready to talk, I'm here to listen. So letting them come at their own time. Understanding and exploring their motivation. So again, providing that decisional balance, right? To say, you say this, but then you say this. You listen with empathy, and then you continue to empower that patient, because it's a dance. You can't force them. They have to come and be ready. Okay, this slide is included here just in terms of some clinical precautions. So certain patient populations, when you're going to start a taper with some patients that you may want to be extra cautious with. So certainly in the pregnant population, any rapid or severe opioid withdrawal is associated with premature labor and spontaneous abortion. So having, collaboration with people that are specialized in the management of pregnant patients in the context of opioid withdrawal is really important. Unstable medical or psychiatric conditions. So certainly opioid withdrawal can cause significant anxiety, which may exacerbate some unstable cardiac conditions or psychiatric conditions. Patients that have misuse or addiction to opioids obtaining from multiple doctors or on the street. So in those situations, an outpatient taper is unlikely to be successful, especially if they're getting it from multiple sources. It's really hard to control that. So I think patients are best managed in more of an opioid agonist treatment program, such as methadone or buprenorphine. And I'm not going to be talking about those two modalities. It's beyond the scope of this talk, but certainly there's a lot of other resources through OPA that you can learn more about methadone or buprenorphine. And then patients that are on concurrent medications, so trying to avoid those sedative hypnotic drugs like benzos during a taper. Now you have patients that come into you with maybe panic disorders or anxiety that are already on benzodiazepines. I think in those situations it's okay to continue that patient because you don't want to destabilize that mental health issue. But in this realm, I'm talking about introducing a benzo in the taper, probably not the safest thing to do. So how do we taper and what are the benefits? So in the blue top box here, it says here that the benefits of tapering, and this is from, anecdotal evidence, and this is from our clinical experience, that really patients start to feel better when they taper. They oftentimes have a reduction in pain intensity. So again, that's that reduction in perhaps the hyperalgesia. And then they have improvement in mood and function. But it's also important to understand that withdrawal from opioids is uncomfortable, but not life-threatening. And that the patients unable to complete a taper may stay in a lower opioid dose if their function improves. Okay, so that's a key thing, to be flexible, that sometimes we might need to pause the taper, and that's okay. And the taper rate can vary. So for example, if a patient is compliant and has been on opioids for many years, there's no need to taper quickly. So you may want to adjust that rate based on negotiation with the patient. You want to make sure the doses are kept scheduled and avoiding PRN use. At the end of taper, so when doses are less than probably 60 to 90 morphine equivalency, you may want to really slow down that taper. So I have a guideline here, about 1/3 of the original opioid doses reached. You might want to do much slower dose reductions. Now again, you can see here the dose reduction ranges from 5 to 10% of the total daily dose every 3 days, weekly, monthly, 6 weeks, what have you. Again, however way you want to approach it, the end goal is to have a reduction in dose and improve safety. So negotiating with the patient gives much more better in terms of how the taper is going to go. In the red box here, I do want to highlight that to provide opioid overdose education through dispensing of a naloxone kit. So really, really important. Particularly for patients as they're tapering. Sometimes, their pain may destabilize and they may be tempted to go back to original dose. And in those situations, that's very unsafe because patients actually lose tolerance to the opioids as soon as 3 to 7 days. As such, they're at risk of overdose. So for my patients who start a taper, we often recommend that they get an opioid overdose kit prevention, such as a naloxone kit, to make sure that they're safe. A couple of other opioid tapering precautions to consider. So warning that patient not to resume the opioid dose. So again, I've talked a lot about that risk of overdose risk if they resume the previous opioid dose, and then never quickly or abruptly stopping that opioid. So patients will go through severe withdrawal and may turn to illicit market for relief. So certainly this is where there's that high risk of overdose because of loss of tolerance. And fentanyl often is added to the illicit opioids, and that's creating a lot of the issues that we're seeing in public health with regards to overdose. So that's all I'm going to talk about in terms of how we taper and you know, the principles around tapering. I'm going to spend a little more time on opioid rotation. This tends to be an area that's a little more complicated with regards to calculating the dose and creates sometimes a little confusion for clinicians. So I think I want to allow ample discussion time to walk you through how we would do a rotation. Now, the rotation you can remember from the opioid guidelines, the evidence to support this practice of switching is largely anecdotal and based on observation and uncontrolled studies. But however, with patients with unacceptable side effects or poor efficacy, we do try to switch to another opioid. And the concept behind a rotation is based on wide inter-individual variability in opioid sensitivity. And because of that, patients often have incomplete cross-tolerance between one opioid to another. So as a result of that, we can have a much bigger dose reduction when we switch to a newer opioid. So an example here is shown in the chart, and this is taken right from the 2010 guidelines, and it hasn't changed from the 2017. Similar concept. So if a patient is on a high dose of opioids, and it's not very clearly defined what is high dose, but I would say it's safe to say anyone above 100 morphine equivalency, for me, I would consider high dose. In those situations, the suggested new opioid dose should be 50% or less of the previous opioid, and then converted to morphine equivalency. Patients of moderate to low doses, so anything below 100 or below 90, I think you can probably safely give 60 to 70%. 75% of the previous opioid, so reducing by 25 to 40% of the previous opioid, and then switching to a morphine equivalent dose.
So these are a couple of key points to think about when you want to engage a patient in an opioid rotation. So how do we approach this? So the first way that I would approach it is first summing the total daily dose of each opioid. So it's not uncommon that patients will present with fast-acting and long-acting opioids. So let's say they're on fast-acting hydromorphone as well as hydromorphone contin. So you would total up the whole amount of hydromorphone they're consuming that day. And then with that total amount, you would convert to a daily morphine equivalency using the equal analgesic dose of the new opioid that you want to convert to. So let's say you want to convert that patient to morphine. So you would convert morphine to morphine, what that new morphine dose is. Once you have that new dose, you would discount that new dose by approximately 25 to 50% to account for that incomplete cross tolerance. So usually I drop about 50% to be more conservative because most patients are on those high doses. And then once you get that final new dose, I may allow some room for titration to effective doses. So what that means is oftentimes, let's say you're switching them to long-acting morphine. I usually recommend about 5 to 7 days or so of fast-acting opioids to allow that patient to titrate up to effective analgesic efficacy. Because we're really guessing with regards to what their final dose will be and what dose would provide them the most effect with regards to pain. Be careful if you are using some fast-acting that the patient is calculating their total dose and that they don't start going beyond that watchful dose. We really want to kind of keep it as low as possible. So we want to make sure that the fast acting doesn't run away from us and that we're using more and more of the fast acting. So again, that fast acting proportion is really for a for a short period of time in terms of dose titration. A couple of other clinical considerations relates to other more complex opioids. So methadone rotations are very complex. Partly because there's no clear morphine equivalency. It's got a very narrow therapeutic range. So really it's best managed by experienced practitioners in the field of addictions that are comfortable with switching to methadone. Buprenorphine, or better known as Suboxone, rotations require a special induction protocol, and it's really beyond the scope of this talk, but certainly there are lots of different resources that can guide you to work around how to induce a patient onto buprenorphine.
Okay, so let's go through here. So as I talked about, there is the opioid analgesic chart conversion table here with the most common opioids, the top 4, I would say. And you can see here if you're converting to oral morphine 30 milligrams. So morphine is a gold standard at 30 there. To convert to morphine, obviously is a 1-to-1. But let's say you're converting to oxycodone. So 30 milligrams of morphine is equivalent to 20 milligrams of oxycodone. So it's a 1.5 times stronger, oxy is, than morphine. And then you look at hydromorphone, again, it's 5 times stronger than morphine. So the example is shown here. So someone's on morphine ER 200 BID, giving you a total morphine equivalency dose of 400 milligrams. Okay, so the first thing is you've calculated all your opioids, and now you want to convert to oxycodone. That's your final end opioid. So if you look at the chart here, to convert from oral morphine, you multiply by 0.667. So 400 times 0.667 gives you a total of 266.8 milligrams, or 267 milligrams of oxycodone. Now, remember we talked about their high or low dose. So the original dose was 400, which is considered high dose. So as a result of that, we would reduce it by 50% to account for incomplete cross tolerance. So half of the oxycodone dose is 133.4 or less. And then you would choose the closest dosage form. So it would be oxycodone CR 60 BID. And again, if necessary, titrate that dose of extended release by using some fast-acting initially for a week to get to that final dose. So in a nutshell, essentially, that's how you would rotate someone. Not to worry, we'll go through a couple of cases to practice that. But I want to highlight here some withdrawal symptoms, and I'm not going to go over each and every withdrawal symptom as you have it detailed in your slide, but I do want to highlight that symptoms can occur early, late, or prolonged, and that depends on the pharmacokinetic of the opioid. So patients on short-acting opioids, their onset of withdrawal will happen within 6 hours, and can last 4 to 10 days, but usually peaks between a day and a half to 3 days, depending. For late symptoms, so the onset for late symptoms is about 12 hours to 48 hours. So these are your common long-acting formulations. Can last 10 to 20 days and peaks around 3 days. And then finally the prolonged symptoms. So those happen 1 to 2 days later. So I'm talking about prolonged opioids like methadone or buprenorphine. And they actually can linger for a lot longer than other symptoms. This is an important education piece for patients so they know when to expect the withdrawal symptoms, how long it's going to last, and when is it going to be the worst time. So you can be proactive in some of the management strategies.
So after we talked about withdrawal symptoms, how do we even think about managing some of those withdrawal symptoms? So I've provided this chart to highlight some of the target symptoms on the left that patients often present with, and then some medications and dosing guidelines to consider. So we'll go through step by step of some of the common symptoms. So the first one is nausea, vomiting. So here I have listed, gravel, ginger, and some doses to consider. We are seeing a lot more clinicians using off-label nabilone or the cannabinoid, which is a synthetic THC, to manage some short-term nausea, vomiting. Prochlorperazine and haloperidol. So again, I haven't listed them based on preference. This is just a list of agents we use, and you would choose based on patient profile and safety and obviously drug interactions. Diarrhea is another common symptom. So loperamide or Imodium, it can be dosed as if you were normally dosing any kind of diarrheal issue. Myalgias or aches and pains is common. So you can really use your basic analgesics such as acetaminophen or NSAIDs. Other symptoms such as dysphoria, lacrimation, rhinorrhea, or itchiness are more non-specific symptoms, but for itchiness, we can use hydroxyzine at that dose listed there. For insomnia, anxiety is a very common side effect that we see for patients. So you can use low-dose trazodone for a short amount of time. So I have 25 to 100 milligrams, or low-dose amitriptyline at 10 milligrams at bedtime for insomnia. When we think about anxiety, again, we can use pregabalin or gabapentin or nabilone for short-term anxiety management. Always remember the importance of sleep hygiene should be emphasized for patients, and to try to avoid benzodiazepines. So certainly if a patient has an underlying anxiety disorder, that requires benzodiazepine, that's a different case. But if they don't, and they develop anxiety secondary to opioid withdrawal, we really try not to use any benzos because we don't want to introduce another agent that has a high risk of dependence, another agent that we would have to kind of taper off again. Okay, so those are kind of the key agents that we would consider for some of those symptoms. And finally, autonomic physical symptoms, a slew of different presentations, but the workhorse in this type of target symptom would be clonidine, which is a prescription item. I've provided some very basic dosing regimen as well as some monitoring parameters from a cardiovascular point of view. Clonidine does affect blood pressure and heart rate. We would use a low dose for a short amount of time if patients are experiencing those autonomic symptoms. Please remember that clonidine must be tapered, particularly if they're using it longer term beyond a week, because if we do stop it immediately, patients can suffer what we call a hypertensive crisis, so they get a rebound hypertension. So if patients are using short-term, meaning 1 or 2 days, you likely don't have to taper, but sometimes patients are struggling with some withdrawal symptoms longer than a week. They might need to be used clonidine for longer. That's when we would consider gradually tapering off the clonidine.
Okay, and then when we do a rotation or taper, it's very important to follow up and monitor the patient closely because it's a very vulnerable time for them. So when we rotate, we may want to contact the patient in about 3 days for tolerance checks. So I'm talking about checking more for overdose risks because we don't know that final dose that we've recommended. Is it too aggressive or it's not enough for the patient? So you want to assess that they're not oversedated and that pain relief is comparable to the pre-switch. I would say, if you ever have any doubt in terms of reduction through incomplete cross tolerance, to be a little more aggressive in the reduction, so i.e. being more conservative in the new dose, because you would rather risk having some withdrawal symptoms than risk overdosing the patient. Tapering, you may want to monitor 1 to 4 weeks, again, depending on how fast you taper. And then once you are stabilizing the taper, you can probably monitor more monthly, depending again on the rate of taper. Each time you monitor, you want to assess for functional goals, so meeting those SMART goals that you've set out together, reduction in pain intensity, or at least not worsening, sleep and physical activity, stress level, any new aberrant behavior that might come about, and then withdrawal symptoms in the initial week or so. You may want to suggest urine drug screening to assess for compliance of the taper or rotation for some patients that have maybe more at-risk behavior for aberrancy and more at risk for misuse. Again, that's that discussion with the patient, discussion with the primary care provider. Some other principles to think about along the roles of tapering and rotating is structured opioid prescribing. So this refers to the use of opioids to treat pain with specific controls in place to ensure safe use. So it's not a guideline, but it's just a safe way of practice. So certainly we talk about patient education is given, so risk and treatment outcomes, education on overdose using the naloxone kit, safe storage and disposal of opioids. Also the implementation of written treatment agreements. So it could be an agreement that is shared between the patient and pharmacist and physician or patient and physician. And I'll show you what that treatment agreement looks like. Shortened dispensing intervals. So again, limiting the quantities or the load of opioids in the community. You remember in the beginning, I talked about how a lot of teenagers who are having opioid misuse issues or mortality and morbidity associated with opioids are getting them from their parents, right? So we certainly don't want to promote the dispensing of 2-3 months of fast-acting opioids, hundreds and hundreds, right? To grease that load in the community. Frequent monitoring via urine drug screening, if applicable, for certain patients. Pill counts, some pharmacists do that, as well as a patch-to-patch program that's been implemented as another change in practice for fentanyl. Here's an opioid written treatment agreement, and I took this straight from the guidelines, and there's many templates online. This written agreement is not a legal contract between the patient and the provider, but it's more of a contract to promote transparency of practice so that the patient is aware of their accountabilities, of what is expected of them and way they should be behaving around the use of opioids, as well as the accountability of their provider, that the provider is committed to providing care to the patient. The provider won't the patient should there be barriers or hiccups along the way in opioid treatment. So it just really nicely lays out what is expected of both parties so that we move forward in a safe and transparent manner. Okay, so the next section we're going to highlight is more along the hows do we taper, how do we promote this discussion. So collaboration with physicians is of course something we cannot avoid, when we're doing the taper. And I think there's a lot of key tensions that often are highlighted when I speak to pharmacist colleagues. Two of the main tensions that come out in the themes that I've heard about is miscommunication when making recommendations. So certainly we always promote to collaborate verbally or written if we have to through a written consult when providing that patient-centered care. Fax is okay for more product-centered care, but really if you want to promote good care from a patient-centered, we really want to collaborate verbally. Sometimes you may want to decide you need direct communication. So a change in dose, any clinical issues, that makes sense to have direct communication. And other times you may be able to delegate certain tasks to your other pharmacy support team. Always very important that you're respectful of the physician's professional judgment and relationship with their patient. Obviously we don't always agree with our physician colleagues, which is fine. And in these cases you would document your judgment and your decision, but it doesn't mean that we should be disrespectful to our physician colleagues, because we certainly need to work together and closely to make this work. The other key challenge is role ambiguity and mismatch expectations. So I think we cannot argue that pharmacists are medication experts. We have by far the most training in pharmacotherapy and understanding behind drug therapy. So I think knowing that, we need to promote that. We are collaborators, and as well as it's important to include your credentials when you communicate with your care providers and other allied health. List your patient-centered services, so really explaining to other healthcare providers what you can provide and what you do in your practice. That you're not just counting medications and labeling vials, that you actually have very great patient services and value add for patient care. Compile a list of complex patients who may benefit from coordinated care, right? And maybe if you have an opportunity, do brief critical appraisals of new evidence or therapies. Whatever you can do to promote your practice. And this, I think, is really important, that this can be sometimes relegated to students. Students are very well trained now coming out of our university programs, and they're eager to help the practice. And this is ways that we can utilize our students to promote our role of the pharmacist. Now, when we document with our physician colleagues or any colleague for that matter, we want to ensure that we're concise, clear, confident, and I can't stress enough to own your clinical decisions. Be confident in what you're recommending. Know that you know your patient, know that you know your drug therapy. One approach is a brief note, including 1 to 3 sentences describing the scenario of the patient, your quick assessment, your recommendation and plan. You want to conclude by welcoming collaboration, and then obviously your contact information and your credentials. So this is one example and one way to approach it, and let's go through a sample documentation to show this. So here I have, Dear Dr. Grant, during a medication consult with Mr. Amir D'Souza, he disclosed that he has been experiencing excess sedation that is limiting his ability to carry out his daily work, with minimal improvement in pain. I educated him on the role of the hydromorph content is playing in this, and that other agents may be preferred to managing his osteoarthritis. He is opening to trying other pharmacotherapy. So that's, again, talking about your scenario, talking about leading into your very basic assessment of the case and what is the issue and the drug therapy issue. So then you recommend tapering off his hydromorph IR while initiating duloxetine 30 milligrams daily times 7 days and titrating up by 60 milligrams per day as tolerated. So being very clear, concise with your recommendations. Please advise, I can be contacted at X. Kind regards, and then you sign off. So again, this is just one example you can use when you are communicating with your physician colleagues. And oftentimes, like us, they're very busy and they don't have time to read through a full long consult, but this gives a quick assessment, recommendation, and plan for them to capture your message. Now, we know in practice that we, as pharmacists, can bill the Ontario government for meds check and meds check follow-up, as well as to bill for pharmaceutical opinions. So remember we talked about the documentation in previous slides. This is where we can use that style of documentation when we're doing that pharmaceutical opinion. There's a link here from the Ontario Pharmacists Association with a template that you may want to follow or adapt when you do the pharmaceutical care opinion. And again, utilizing our students, right? I think, oftentimes in practice, we're so busy to do this. So if we can come together with students or bring together a group of patients that you think would have value add in doing these further assessments, this is where we can show our value as pharmacists, both to the government as well as our colleagues. So some documentation etiquette, and I don't need to, promote this too much, but it's also good for me to remind myself when I document that we have to be professional, making sure we check our spelling and grammar, avoiding accusation or any negative tones in our communication, being diplomatic, so avoiding those judgmental words, so going back to being respectful, right? So not using strong words like must or wrong or unreasonable. Being as clear as possible, so objective, sticking to the facts and what the patient reports. Clarify acronyms and abbreviations just from a safety perspective. Plain language and avoiding those unnecessary words. So, here are some examples. So oftentimes I'm guilty of this. You might say, I am of the opinion that. You can just say I think or I believe, despite the fact that, though, for the purpose of, for. So again, just removing all these quote unquote flowery terms that might dilute that message you want for the physician, and helping the clarity of the documentation and keeping it nice and succinct for that physician to understand where you're going with your recommendation. In addition, I think it's also very hard as clinicians to keep up with the evidence and to feel supported, right? So chronic pain, especially if you have a patient with chronic pain and mood sequelae as well as maybe misuse issues, it's a very complex patient to deal with. So there's certainly a lot of supports and mentorship that's available for pharmacists to participate in. To learn more about this. So one big program I want to talk about is the Extension for Community Health Outcomes, ECHO, and they have a branch that focuses on chronic pain and opioid stewardship. So this is a team that links expert interprofessional team based out of University Health Network at TRI with primary care providers in the community across the province. And this could be providers such as pharmacists, nurses, doctors, OTPTs. You don't have to be a physician to join this. So really, essentially, the primary care providers, or yourself, are the spokes of the models, and they become the learning and support community. And as a result, you receive mentoring and feedback from that team of experts at TRI on complex chronic pain issues. So really, it's promoting knowledge transfer through a case-based learning module. So this team meets every week for about 2 hours video conferencing every Thursday. It starts off with a 20-minute didactic presentation by a specialist at TRI, be it on, urine drug screening, opioid tapering, opioid rotation, aberrant behavior, to name a few. And then this is followed up by 1 or 2 patient cases that is presented by yourself or another clinician outside of Toronto, the spokes of the model, right? And then questions and suggestions are provided by participating primary care providers. And then the interprofessional team also can pipe in and provide that support. So the beauty of that is that the case presenters are then provided with a list of recommendations generated from the sessions, and they can apply that immediately to the care of their patients. So I think this is an excellent opportunity if you have opportunity and time to sign up, and the website is listed there for you to look into more. Couple of other online mentoring. So this one I included because I had given this talk similar to physicians, is for the physician group, so medical mentoring for addiction and pain, the MMAP. But very similar to that, we also have the PMAP, which is a pharmacist mentoring for addiction and pain, and that is spearheaded by Bess Spruill over the Center for Addiction and Mental Health. Similar concept. It's a way to support pharmacists in pain management and addiction. And you're often paired up with mentors via telephone or email or fax to kind of discuss cases. We also have an online forum where we post cases and interesting articles and development where you can go on and learn more about the management of chronic pain and addiction. TAPME is a Toronto Academic Pain Medicine Institute. So this is an institute where I work at. We're based at the Women's College Hospital, and we are a chronic pain program with partnerships with 5 academic teaching hospitals. So the partners that we have are including UHN, St. Michael's, KMH, the Women's College itself, as well as the Wasser Pain Clinic at Mount Sinai. So we partner with their chronic pain programs. And the hope is that we are the hub of chronic pain in GTA. Patients are referred to us. We provide programming in terms of self-management programs, as well as pharmacy consultations through myself, PT, OT, social worker, and psychologist. But then we also have linkage to those partner sites to support pain management. So the hope is more of a one-stop, collaborative, streamlined approach to managing pain. And we have resources on this website. So we're launching our large website listed there with tons of tools and tons of links to programs to support the primary care. U of T has a safer opioid prescribing program, a webinar and workshop that you can look at, probably more geared to the physician group. KMH has a lot of excellent online courses ranging from opioids in chronic non-cancer pain to ODT or opioid dependence courses through methadone and buprenorphine, MI courses or motivational interviewing courses. Medify is also another initiative to integrate addiction care provided by emergency departments and hospitals and community programs. In this website, Medify is based out of Women's College, run by Dr. Meldon Kahan. There's lots of great tools and links to education in the realm of chronic pain and more in the link of addiction for primary care. So again, some very excellent resources to look at. And then to lead off, a couple of other resources through the Michael G. DeGroot National Pain Center. So this is the pain center that developed the opioid guidelines. Certainly they have the guidelines, but also other tools that are appendices to the guidelines that you can find very helpful in managing opioids. CADIF has lots of very good, what we call opioid evidence bundles. So I've listed just a few here that might be of interest to you, but these are quick one-page review of the evidence on certain topics. So this here shows buprenorphine or buprenorphine versus methadone in the treatment of opioid dependence. There's also pain medicine evidence bundles. So outside the realm of medication, but there's also reviews on physiotherapy or reviews on CBT in the management of chronic pain. So I find this an excellent site to go to get quick information about the current state of evidence for pharm and non-pharm evidence. Okay, so let's end the last few minutes to discuss two cases that kind of work on some of the principles that we've talked about through this webinar. So case one here shows Mrs. KR is a 67-year-old teacher who injured her left knee when she slipped on ice 4 years ago. She no longer works and is on disability. Over the year, her knee pain has progressively worsened, and now it's persistent, deep, aching at rest, and it's rated at 8 out of 10. That's worse. So pretty severe pain. She experiences burning pain radiating down her legs and notes that the skin around her knee is super sensitive to light touch. So again, we're talking more of a sensitivity and neuropathic pain. And she has a history of left knee OA. She's taking the medications listed here. And with the medications, she reports that her pain just goes down 8 out of 10 to 6 out of 10. She is noticeably upset and frustrated with her pain and is very concerned that she hears that her 24 milligram capsule of hydromorphone is no longer covered through Ontario Drug Benefit because it's being delisted. So thinking about this case, what are some clinical considerations that help you evaluate whether, one, ongoing opiates is indicated? What other things would you evaluate in Mrs. KR's medication history when you assess her whole pharmacotherapy regimen? And how would you adjust her medications to improve her pain? So here I've highlighted a couple of things that I would consider. So from a clinical consideration, I think that going back to the principles of pharmacy, we always want to look at safety, efficacy, adherence, cost, right? So certainly we want to check, is her opioids and her other drug therapy efficacious? Efficacious being functional goals, being reducing the pain at least 30% on the visual analog scale. Is she experiencing medical complications? So this talks about the safety aspect of opioids. And is there presence of concerning aberrant drug-related behavior? So again, around safety and misuse. So making sure we assess each of those parameters for opioids. I would say if you think back to her case, she says her pain goes down 8 out of 10 to 6 out of 10, despite those high doses. So in my mind, it's not very efficacious, and certainly probably her function has been decreased. Does she have other medical complications? It doesn't sound like it, but certainly if you dive a little deeper, she may describe, constipation. She may describe more hypersensitivity around her knees. There might be risk for sleep apnea. But again, those are things that we use to suss out that safety. And then doing a quick aberrant drug-related behavior check. So you as the community pharmacist know how often she fills. Is she coming in early? Is there concerns about manipulating the dosage strengths? These are things that I think are valid to ask the patient, normalizing it and making sure that you're assessing for these aberrant behavior. What other things do you evaluate for Mrs. KR? So we think about, again, appropriate medication history, effectiveness, safety, cost, and adherence. So we want to check about her duloxetine. Is it optimized? Is she at a good enough dose? Is she tolerating it? And if that's not working well for her, what about optimizing other agents, looking at other adjuvant agents for her neuropathic pain, such as pregabalin or TCAs? So certainly I'm not going to get into the details on that, but that's something to think about when we look about whole pain management. Opioids is one piece, but certainly we want to optimize our other adjuvant therapies. And what about other opioid trials? So then you start to think about what are other options. If her hydromorphone is not working, she's been on it for a long time at a high dose and not getting clinically significant benefits, what are the things that we think about aside from adjuvants? And then the last thing is, how do we adjust her medications? So I think I'm trying to lead you into a care plan of perhaps that we might need to rotate. So in this case, as an example, I decided to rotate to fentanyl patch, and I thought I wanted to talk about how to do this because it's more of a complex medication to rotate to. Certainly you can rotate to oxycodone or morphine if she hasn't tried in the past. But let's walk through how we would do this. So her total dose of hydromorphone is 3 of the 24 milligrams, so that's 72 milligrams, plus she gets some fast-acting 12 milligrams. So it gives her a total dose of 84 milligrams of hydromorphone. You recall from the dose conversion chart that hydromorphone is 5 times as strong, so 84 times 5 is 420 milligrams per day of morphine equivalency. This is considered high dose, so we reduce this by 50% to account for incomplete cross tolerance. So 420 divided by 2 gives us 210 morphine equivalency or less. And then when you look at the conversion chart in fentanyl, this equates to approximately 20 microgram patch per hour, Q72 hours. So that's essentially how you will rotate. That's the kind of the final dose you come to with regards to fentanyl. But I think the key thing as pharmacists is to understand, when do we apply the patch? When is her last dose? What's the timing of all this? So when should the patient apply the fentanyl patch in relation to her last hydromorphone content dose? So in this sense, we should be applying that patch the same time as her last dose. The reason is it takes 12 to 16 hours for fentanyl to reach its therapeutic, or what we call peak levels, where that drug starts giving analgesic effect. So if it takes 12 to 16 hours, if we give it the same time as a hydromorphone, her hydromorphone dose should technically last for 12 hours. So she would hold her over until that fentanyl patch kicks in. And once it kicks in, then you would stop the hydromorphone. When should the dose of fentanyl patch be increased? How long you would wait? Generally, we recommend for new starts of fentanyl patch, we would wait 3 days after the initial patch before we would increase the dose, and then every 6 days thereafter as we reach that steady state. So again, just going back to kind of almost pharmacy 101, understanding the kinetics of the drug, understanding the onset of action, half-life of fentanyl, or half-life of the agent that you're switching from will really guide you in terms of how you do that switch. But just be really careful because fentanyl is a more complicated medication to double check your calculations. And, it doesn't hurt to review with colleagues to make sure you're providing that correct dosing recommendation. The second case talks more about how do we streamline opioids. So Mr. VD here is an overweight 60-year-old male nurse. 4 months ago, he injured his back when lifting a patient out of bed. Since that time, he reports sharp, intermittent pain in his lower back, which radiates down his right leg to the lateral aspect of his calf. His pain has significantly disturbed his sleep, and an MRI of his lumbar spine shows indeed that there's an L5-S1 disc herniation with some nerve impingement. He has a past medical history of hypertension, dyslipidemia, and insomnia. And he's taking a slew of medications here, so 2 fast-acting opioids, some diclofenac with a recent dose doubling, some Imivane for sleep, and some other agents for his cardiovascular disease. With these medications, his pain is reduced from 8 out of 10 to 4 out of 10, so that's pretty good. So you can see there's a significant dose reduction, pain reduction. But he describes shakiness, mild nausea, and muscle aches all over his body first thing in the morning. And he also mentions that he hates taking so many tablets. So again, here I'm building up the case that there's little clues here that tells you that we need to reassess his current opioid therapy. So again, the similar clinical considerations to evaluate his current therapy. Looking at appropriateness. Is it appropriate to use 2 fast-acting agents? Is there evidence supporting that? And as well as 2 different type of opioids. And I can tell you there's not a lot of evidence supporting fast-acting opioids in the context of chronic pain, and for that matter, different opioids. Is it effective? So yes, it is effective. So he's getting that 50% reduction. Is it safe? Well, we'll calculate the morphine equivalency dose to determine that, and we also do that check with him in terms of any side effects. Cost, and then adherence. So he already complained to you that he doesn't want to take so many medication tablets. So again, there's an adherence challenge here. So maybe there's better ways we can streamline the therapy. Efficacy, complications, and parent presence of concerning aberrant behavior. So again, doing the similar questions and checks. So here, I think what I'm going to recommend is to streamline to oxycodone CR. All right. So barring that he has no risk of misuse, we've decided that oxy-CR is a safe option for him. How do we do this? So his total oxycodone dose currently is 20 milligrams per day. His total codeine dose is 240 milligrams per day. We want to make sure that we are calculating and adding all these opioids together to come out with final morphine equivalency. So first of all, let's deal with the oxycodone. So we want to convert to morphine, so which is 1.5 times stronger. So 20 times 1.5 is 30. So that's 30 morphine equivalency coming from the oxycodone. Then the codeine conversion is 0.15. Codeine is much weaker than morphine. So again, 240 times 0.15 is 36 milligrams of morphine equivalency coming from the codeine, giving you a grand total of 66 milligrams morphine equivalency. So he's below the watchful dose. So I would say that it's okay. He's getting good benefit. Now with that, you want to convert all to oxycodone, right? So 66 milligrams of morphine is equivalent to 44 milligrams of oxycodone because it's 1.5 times stronger, right? So you do that division or look at that chart and to do that switch. Now the trick here, there's no need to account for incomplete cross-tolerance because we know that he's tolerant to oxycodone. He's been on oxycodone and he's tolerating it. So in my mind, we don't need to decrease the dose by 25%. We can keep it at that current dose, just making sure that we're streamlining and calculating the final oxycodone dose. So with 44 milligrams per day of oxycodone as his new morphine dose, or new opioid dose, not morphine dose, opioid dose, you streamline it to oxycodone CR 20 twice a day because it's available as a 20. So that's essentially what I would do in terms of opioids. What about his other agents that we want to optimize as well? So what's the role of Mr. VD's NSAIDs in his pain condition? Are there clinical considerations that make his current NSAIDs not a safe option, right? And so in this situation, you want to consider each of the drugs. So think about his cardiovascular risk factors. So you know that he has a history of hypertension and dyslipidemia. He's overweight. And he's probably on what we consider more of a higher dose of diclofenac. So that puts them at a higher risk of CV mortality. We know from epidemiological studies that diclofenac is one of those offending agents in terms of increasing that risk of CV, morbidity and mortality. And furthermore, he's recently doubled his dose, right? So we might want to suggest decreasing his dose or even switching to a completely different NSAID, such as naproxen or even low-dose Celebrex, which are considered more CV neutral drugs. So you need to appreciate the CV risk associated with long-term high-dose use of COX-2 inhibitors and also other non-selective NSAIDs when we do that complete risk assessment. And then lastly, but also just as important, is other adjuvant pain medication that would benefit him. So perhaps we want to suggest initiating a first-line adjuvant agent. You remember in the case he had significant findings for nerve impingement at the S1, so certainly probably had some nerve irritation to the nerve roots, causing exacerbating his pain experience. So you may want to consider initiating maybe TCA, barring that he doesn't have any QTC prolongation or any contraindications to his TCA. You may want to consider maybe pregabalin. Again, this tends to be a cleaner gabapentinoid with better pharmacokinetic profile compared to gabapentin. It might be helpful for some sleep. Again, so barring that he doesn't have any contraindications. And then the third one is duloxetine. So again, starting at the low dose and titrating to optimal doses of 60 to 90. Again, great evidence for pain, neuropathic pain, OA pain, as well as depression, and then generally well tolerated. So again, those three agents, TCAs, pregabalin, duloxetine, are considered first line in neuropathic pain, and the choice of them depends on his comorbidities and what we expect in terms of safety and benefit. So those are some things you want to consider as well as part of your care plan. And then also, I forgot to mention that, once we get him stabilized from a pain perspective, maybe we want to decrease or discontinue the Imavane, right? And then making sure that his bowels are well managed from the opioid perspective, right? So, your osmotic or stimulant laxatives to ensure that he has good coverage. So I thank you very much for taking the time to listen to this online webinar or online module for opioids and safe use. And I hope it was helpful for you in navigating through the management of these very challenging patients and giving you some food for thought of approach, giving you some resources to look to if you run into a bit of roadblocks, and giving you a couple of cases to review some of the concepts we talked about today. Thank you very much, and all the best.